Podcast 4 of the Abdomen series, the small intestines. This podcast will describe the anatomy of the small intestines, including the duodenum, the jejunum and the ileum. I'm going to detail their structure, location, peritoneal relations, blood supply and autonomic innervation. So the small intestines can be divided into three parts: the duodenum, the jejunum and the ileum. And these three parts are primarily responsible for absorbing nutrients from the ingested food. It extends from the pylorus of the stomach to the cecum, where it forms the ileocecal junction. So let's start by detailing the duodenum. So the duodenum is a direct continuation of the pyloric canal and receives the contents of the stomach under the control of the pyloric sphincter. It is approximately 25 centimeters long and takes its name from the Latin duodenum digitorum, which translates into 12 fingers, and initially this was how the length of the duodenum was first described. As it extends from the pylorus, it takes a C-shaped course surrounding the head of the pancreas and is continuous with the jejunum at the duodenal-jejunal junction. Along this course, the duodenum can be divided into four parts. Initially, there's the superior, or the first part, then there's the descending second part, a horizontal third part, and finally the ascending fourth part. Now, most of the duodenum is retroperitoneal, so it's positioned between the posterior abdominal wall and the peritoneum, but there is a small section of the first part of the duodenum that does have a mesentery, and this piece will therefore be intraperitoneal. So let's detail these four parts. The first, superior part of the duodenum is a direct continuation of the stomach, and it extends slightly upwards and to the right. It is about 5 centimeters long and lies anterolateral to the body of the first lumbar vertebra. The majority of the first part is retroperitoneal, with only its anterior surface having a covering of peritoneum. The first 2 centimeters, however, is mobile due to it being suspended by the two ommenta. So this initial part is known as the duodenal ampulla or cap, and superiorly it is suspended from the liver by the hepatoduodenal ligament, which, remember, is part of the lesser omentum. Inferiorly it has the descending layer of the greater omentum. So the first 2 centimeters of the first part of the duodenum is intraperitoneal and is suspended within the abdominal cavity by the hepatoduodenal ligament and has the greater omentum hanging from its inferior surface. The second, descending part of the duodenum is slightly longer at about 8 centimeters and extends downwards along the right sides of the first to third lumbar vertebra. It curves around the head of the pancreas. This second part is completely retroperitoneal and therefore does not contain a mesentery. Along its posteromedial aspect is the hepatopancreatic ampulla, or the ampulla ovata, and this is a small dilation formed by the union of both the major pancreatic and bile ducts. This ampulla empties both the pancreatic juice, or the bile, into the duodenum via a small opening, the major duodenal papilla. Slightly superior to the major duodenal papilla is the minor duodenal papilla, and this drains the minor pancreatic duct. I will detail these ducts and how they are formed in relation to both the liver and pancreas in podcast 7, which details the biliary tree. Now, the major duodenal papilla is an important landmark within the duodenum, as it demarcates the end of the foregut and the beginning of the midgut, and as I will detail, this means the duodenum receives its blood supply from 2 different sources. The third, horizontal part of the duodenum extends to the left, across the inferior vena cava, descending aorta, and the third lumbar vertebra, and gives rise to the fourth, ascending part of the duodenum. This part extends upwards along the left side of the aorta to the inferior border of the pancreas, where it then turns anteriorly to merge with the duodenum at the duodenal-jejunal junction. This junction is supported by a suspensory muscle the ligament of Treitz. This is formed by a small slip of skeletal muscle from the diaphragm and a fibromuscular band of smooth muscle from both the horizontal and ascending parts of the duodenum. This ligament is believed to aid the movement of food through the intestines by widening the duodenal-jejunal angle. Now, as the duodenum lies deep within the abdominal cavity, it is related to numerous organs and vessels. So I just want to go over the relations of the duodenum. The first part of the duodenum lies at the level of the first lumbar vertebra and has the gallbladder and liver anteriorly, the bile duct, portal vein and inferior vena cava posteriorly, and the neck of the pancreas inferiorly. The second part of the duodenum lies to the right of the first to third lumbar vertebra and has the coils of ileum, transverse colon and transverse mesocolon anteriorly. Posteriorly there is the hilum of the right kidney and its vessels and ureter, and the right psoas major muscle. Medially there is the head of the pancreas and both the pancreatic and bile ducts. The third part of the duodenum lies anterior to the third lumbar vertebra and has the superior mesenteric vessels and coils of ileum and jejunum anteriorly. Posteriorly there is the right psoas major muscle, the inferior vena cava, aorta, and the right ureter. And superiorly there is the head and uncinate process of the pancreas, and also the superior mesenteric vessels. The fourth part lies to the left of the third lumbar vertebra, and anteriorly it has the beginnings of the root of the mesentery and the coils of jejunum. Medially there is the head of the pancreas, and superiorly is the body of the pancreas. Now the internal mucosa of the duodenum is thrown into a series of circular folds known as plicae circularis, and it also has an abundance of microvilli. It differs from the jejunum and ileum by containing Brunner glands, and these secrete an alkaline mucus which protects the duodenum from the acidic chyme and also brings the pH to the level at which the pancreatic enzymes are most effective. So to finish this first part of the podcast on the duodenum, I want to detail its arterial supply and venous drainage. And before I mention this, I just want to detail that the major duodenal papilla is the landmark for the division between the foregut and the midgut. So within the second part of the duodenum, the major duodenal papilla marks the beginning of the midgut and the end of the foregut. And this means that a duodenum is going to receive its arterial supply from two arteries: the celiac trunk, which is the principal artery of the foregut, and the superior mesenteric artery, which is the principal artery of the midgut. Now both of these arteries give rise to pancreatico-duodenal arteries, with the proximal part of the duodenum up to the major duodenal papilla being supplied by the superior pancreatico-duodenal artery. This artery comes off the celiac trunk via the gastroduodenal artery. The distal part of the duodenum is supplied by the inferior pancreatico-duodenal artery, and this is a direct branch off the superior mesenteric artery. These pancreatico-duodenal arteries are positioned in the curve between the medial surface of the duodenum and the head of the pancreas, and therefore supply both of these structures. And as they do that, they form numerous anastomoses at the level of the foregut-midgut junction. It is important to recognise this transitional area between the foregut and midgut, and know that all the structures in the midgut are now going to be supplied by the superior mesenteric artery, and not the celiac trunk which supplied the foregut organs. The venous drainage of the duodenum is going to follow the same course as the arteries, with these veins draining into the portal system via either the splenic or superior mesenteric veins. So now in the second part of the podcast, let's turn to the jejunum and the ileum. So the jejunum and the ileum are the distal two parts of the small intestine, measuring about 6 to 7 metres in length, but this length is fairly variable from person to person. The jejunum is a direct continuation of the duodenum at the duodenal-jejunal junction, and this is where the small intestine regains its mesentery and becomes intraperitoneal again. After approximately 2 to 3 metres, the jejunum becomes the ileum, and this then extends to the cecum where it forms the iliocecal junction. It is important to note that externally there is no noticeable features which separate jejunum from ileum. There is only a gradual change in characteristics along its course. So what are the main differences between the jejunum and the ileum? Well, firstly, in the living person, the jejunum has a deeper red colour owing to its greater vascularity. It has thicker walls, a wider lumen, and an increased amount of fat in the mesentery. The ileum is a paler pink colour, it has thinner walls, a narrower lumen, and has a lower amount of fat in the mesentery. Internally, and like the duodenum, the internal mucosa of both the jejunum and the ileum is thrown into circular folds, with the jejunum having larger, taller, and more closely packed plicae circularis. The ileum has fewer of these, and most distally, these plicae circularis are absent. Now, before I detail the blood supply to the jejunum and ileum, I just want to mention the mesentery in a bit more detail. So the mesentery, which anchors the jejunum and the ileum to the postero-abdominal wall, is fan-shaped, and its root runs obliquely from the duodenal-jejunal junction, which is to the left of the second lumbar vertebra, to the iliocecal junction at the level of the right sacroiliac joint. As the root passes obliquely across the infracolic compartment, it crosses the fourth and third parts of the duodenum, the abdominal aorta and inferior vena cava, the right ureter, the right psoas muscle, and the gonadal vessels. Running within the mesentery, between its two layers, are the superior mesenteric vessels, autonomic fibres, lymph nodes, and variable amounts of fat. Now, as both the jejunum and the ileum are part of the midgut, they will therefore be supplied by branches from the superior mesenteric artery. As the superior mesenteric artery, which leaves the abdominal aorta at approximately the L1 level, runs through the mesentery, it gives off approximately 15 to 20 branches, which radiate to the left and supply the jejunum and ileum. These are the jejunal and ileal arteries. As these arteries approach the jejunum or ileum, they unite to form arterial loops, known as arcades. These arcades then give rise to a series of straight arteries called the vasa recta. The arcades that supply the jejunum form large loops with long straight vasa recta coming from them. But as the jejunum becomes ileum, these arcades become shorter, giving off short vasa recta. The venous drainage of the jejunum and the ileum mirrors that of the arterial supply, with jejunal and ileal veins draining to the portal system via the superior mesenteric vein. So to finish the podcast, I will just briefly go over the autonomic innervations of the small intestine. The autonomic innervations of the small intestine predominantly arise from the superior mesenteric plexus, which is a collection of nerves that surrounds the superior mesenteric artery. Sympathetic fibres coming from this plexus will reduce gastrointestinal motility and also vasoconstriction of the jejunal and ileal arteries, thereby reducing digestion. Parasympathetic fibres arising from the posterior vagal trunk will promote gastrointestinal motility and also vasodilation, and these will restore the level of digestion. So in this podcast, I've given an overview of the small intestines, including the duodenum, jejunum, and ileum. Now, before I do finish, I just want to remind you that in podcast 8 of this series, I'll give a more detailed account of the arteries and portal system of the abdomen, and in podcast 11, give more details about the somatic and autonomic nerves. In the next podcast, number 5, I'm going to detail the anatomy of the large intestines.